Well, I took a bit too long once again in getting this show together, but it's a really good one and I hope you will like it. Since we last spoke, I have created a new website, iguy.tv, that's IGUY.tv, just to handle redirects to all my web content, and a Talking About Glaucoma subreddit to collect glaucoma-related articles from anyone who wishes to contribute at iguy.tv/reddit, and Reddit is REDDIT. In case you were wondering, I have lots of excuses for not getting this podcast ready in a timely manner. Here is yet another conversation that dates back to last year's American Glaucoma Society meeting, this time with Alfred Solish discussing what he refers to as slit lamp revision of filtering blebs, but what most of us refer to as bleb needling. Welcome back to Talking About Glaucoma, the podcast of indeterminate frequency, in which I talk with glaucoma colleagues about hot topics in our field. This is episode number 19 for February 2012. I'm Robert Schertzer, Clinical Associate Professor at the University of British Columbia, Department of Ophthalmology and Visual Sciences, and Director of the West Coast Glaucoma Center in Vancouver, BC, and we're talking about glaucoma. I'm here today talking with Al Solish, and we're going to talk about bleb needling, something he has more than just a little bit of experience with over the years.
You know, it's very interesting, the idea of using a fine gauge needle to revise a filtering bleb. I actually thought of this first when I was a resident at UCLA. I noticed that there were a couple of patients who had just a little bit of fibrous membrane over their bleb, and I said, gee, why don't we just lift up that scleral flap? And I looked at the histology of failed blebs and said, you know, those membranes are fairly thin. We ought to be able to get that with a needle. So I went to my attending, and the attending said, "You're a dummy." I said, he said, "Look, they failed after you've done
the good old days."
The good old days, yes. You're a dummy, and you know the idea is that the reason they failed because there is wound healing and fibroblast proliferation, and a needle, all you'll do is just you'll open it up again and it'll close right up. And in fact, you're going to make a much smaller opening with the needle, so you're not going to get a good result with this." And I said, you know, you're right. I'm not too bright, but I never lost the thought. And a couple of years later, I was in Arvo, and I noticed there was this guy named Rich Parrish who was talking about something called 5FU, which was a wound healing modulator. And I said, now there's something. And as fate would have it, I did my fellowship at Washington University in St. Louis, where they were part of the 5-fluorouracil filtration study. And so I got the opportunity to use the 5FU in the early days of that. And so when I started my practice in LA, I decided to try my idea of needling using an antimetabolite. And I was wondering what kind of a control I could use, and so I needled people without an antimetabolite first to be sure that this would work. And if that didn't work, I would needle them with 5FU. And I did this on about 30 patients, and I got about a 75%, I can't remember exactly the number, 75% success rate. You can look it up. It's at an Arvo poster from 1989. And they needed between 2 and 3 needlings to get a successful result.
Now, were these flat blebs, or were these blebs that were slightly raised or insisted looking? I mean, there's a whole range of bleb appearances.
It's really interesting. I don't remember because I didn't look at that specifically. I was just looking at people with high pressures, and I wondered if I really had to take them back to the OR and do a 5FU filter, or whether this little slit lamp procedure. In fact, I don't even call it bleb needling. I call it slit lamp revision. I think bleb needling sort of trivializes a very serious operation. So when I do a slit lamp revision or an SLR, I prep them the same way I would for the OR, although I don't use a lid speculum because I think my thumb has a lot more control of a lid than a speculum does. They can blink out specula and so forth. Anyway, it seemed to work very, very well. It was... what was his name of balanced salt solution in the operating room? But he proved that it was safe, and I've been using both mitomycin and 5FU ever since. What was really interesting that I did look at the difference between encapsulated blebs later on after my original presentation. I did look at the difference between encapsulated blebs and non-encapsulated blebs, and needling with encapsulated blebs failed 100% of the time. and needling of non-encapsulated blebs were the ones that succeeded. So it was really interesting because when I first proposed this and said, why don't you do a needling or a slit lamp revision, people would say, well, we do that for encapsulated blebs. And I said, no, that's the person you should not do it on, because they really don't work. You can use that as a temporary decompression until the encapsulation thins out, and many of those will recover spontaneously, as I have just learned it with Vidal Costa, who did a paper on that. But on the other hand, I think that needling is a very valuable armamentarium. It shouldn't work permanently, just like the original filter didn't work permanently. But you might get an extension of your filtering bleb. It works best in patients who've already had a successful bleb for some years.
Right, we were talking about that earlier. Those patients, they come back to you 10 years later, their pressure's up, and one needling and it works and it just stays working.
Because I think those people have already sort of a successful cells. The group in San Francisco always talk about follow the cells. John Polanski and George Alvarado always used to talk about follow the cell. You have to think like a cell. And if the cells in an individual are primed to allow fluid to pass them, you'll be fine. And if the human body doesn't like holes in it, and if your fibroblasts are ready to close this off, then they will.
Be the cell.
Sort of. It sounds a little bit weird, but I think that we shouldn't ignore the fact that the cells of the patient are what's going to determine the result. It was actually Bob Schaefer who told me that it's always the quality of the patient that determines the result, not the quality of the surgeon.
Absolutely. Thanks so much, Al Solish, for talking today. Well, that's our show for today. If you like this podcast, please subscribe to the RSS feed at wholelotofrob.com, iTunes, or by searching within your podcast player on other devices. I've created new shortcuts for both the AAC version with artwork and chapter markers and the mp3 versions that you can manually enter into your podcast player as http://iGuide.tv/podcast/RSS-AAC or iGuide.tv/podcast-RSS-MP3. Even easier, just go to iGuide.tv for a full list of all my shortcut links to my bits and bytes that are all over the net. You can follow me on Twitter by going to iGuide.tv/Twitter or by following Rob Schertzer on your Twitter app, and check out my office website at iGuide.tv/office or westcoastglaucoma.com. Feel free to drop me a line at podcast@iGuide.org for feedback, including topic ideas. And if you have subscribed through iTunes, please rate Talking About Glaucoma in the iTunes store. Please help detect and treat glaucoma by keeping yourself informed. As a reminder for Canadian ophthalmologists, each podcast episode is worth half a credit in the new Section 2 under Podcasts. You can also use any podcast to inspire you to learn more about a topic and earn even more CPD credits, because personal learning projects are now worth 2 credits per hour. This will help make up for the fact that teaching in the clinical setting is no longer recognized for CPD credit. So subscribe to this podcast, tell your friends about it, and bug me to complete more episodes.